So my talk today is a topic that's near and dear to my heart, AI spatial biomarkers. And I always like to start with a little bit of history. So the job of the pathologist has always been to classify disease, and we classify really to predict outcomes, right? And the things that we're trying to predict are really which therapy choices people should undergo. So even from the earliest time, like finding a mass in a breast, it was recognized that some masses are bad, some masses aren't bad. As we delve in deeper and deeper into more and more insights, we can figure out which patients actually need therapies and which patients don't. And of course, our options are always limited by the therapy choices that exist. So when I started my training, therapeutic options for cancer were really limited to surgery, chemotherapy, and radiation therapy. And so it wasn't a big surprise that during my training, most of the things that we focused on were prognostic markers. Does the patient need therapy at all? And if they need therapy, do they get a primary therapy, and do they need secondary therapies? One of the great quotes from Sir William Osler back in the late 19th century was, if it weren't for the great variability among individuals, medicine might as well be a science and not an art. And of course, our job is to move medicine into a science. And we're doing that by better understanding the variability among individuals. That is largely just starting to move forward with our understanding of germline next generation sequencing. And of course, the famous Weinberg paper from the early 2000s, really identifying the hallmarks of cancer and leading us into the concept of precision medicine, trying to understand why cancers are different from each other and why different therapies might provide better benefits for individual patients. And of course, the concept of precision medicine we're all pretty familiar with, that before the concept of precision medicine, you would get a diagnosis of X, and all the patients with that classification were treated the same way. Some people would get benefit, some people wouldn't get any benefit. Not only when some people get benefit, some people might get just adverse effects. And the idea of precision medicine is to better delve into the individual and their tumor, generally through a diagnostic test that allows us to subclassify patients where we can tailor a therapy, with the goal being that each patient receiving that therapy would be a responder. Of course, the world doesn't work that perfectly. And the concept of biomarkers were created really at the time of the launch of trastuzumab for HER2-positive breast cancer. The concept was recognized that if we're going to treat HER2-positive breast cancer, that we need to understand the patients that are HER2-positive. And so that's done with a biomarker. We developed several that would identify a population that was most likely to benefit from the disease. But unfortunately, our biomarkers are not perfect. So the goal of the biomarker, if it were perfect, would be to identify only those patients that would benefit from the disease. We can't be that good. So we try to get a subset of the population that might benefit from the particular therapy choice. And the job of biomarkers since they were created, so since I started doing this in the late 90s, we always strive to improve biomarkers. And we can improve biomarkers in two ways. One, we can improve the training of pathologists and better assays to better define the population that might benefit from disease. And we're using AI, as I'm going to describe, in many ways to do this now, to improve how a pathologist might interpret a result. But of course, as therapies are getting more complex, we also need to improve the biomarkers that we have, and we need to think of biomarkers in a much broader sense, not necessarily one biomarker for one therapy, but how biomarker or biomarkers might work together. So the concept of discovering new novel biomarkers becomes critically important. And biomarkers come in many, many flavors. Some are really easy to perform globally, like histology. Every lab around the world has the capability of taking a portion of tumor, fixing it, creating a tissue section, staining it with an H&E stain, and classifying the disease through pathologist training. We've become almost as global with that in immunohistochemistry. And we've got emerging fields of transcriptomics, next generation sequencing, et cetera, which are fairly common but not globally available, and certainly not available quickly and inexpensively. Now, the key to any sort of targeted therapy, as I said, is the biomarker. And the reason that precision medicine and targeted therapy got its legs is because targeted therapy improved patient response. It also improved progression-free survival. Unfortunately, most of the targeted therapies, our early targeted therapies, had overall limited survival benefits. So a great benefit for the patient in terms of quality of life, much better response rates, much fewer side effects, et cetera, but still limited overall survival benefit. And then more recently, we've had the emergence of, or the reemergence, I should say, of immunotherapy and the emergence of checkpoint inhibitor therapy, really producing some astounding results, taking some patients with metastatic cancer and within weeks, in essence, making that tumor disappear. And you can see a PET scan image on the far left with those black dots studying areas of metastatic disease that, 6 weeks following checkpoint inhibitor therapy, those tumors virtually disappearing. And a patient in the middle with an obvious melanoma on their face, treated again within a few months, virtually disappearing. And the exciting part of checkpoint inhibitor therapy was the potential long-term survival benefit, but only in a subset of patients, unfortunately. Now, there were many differences that we noted between targeted therapy and immunotherapy. I'm not going to go through all of them, but relative to biomarkers and to effects, with targeted therapy, the benefits were seen early, but the duration of benefits were somewhat limited. And our biomarkers were really focused on the tumor cell itself. Whereas in immunotherapy, the benefit wasn't always necessarily seen early, but many patients, or at least some patients, got an extended duration of benefit. And the biomarkers were focused not just on tumor cells, but now on tumor cells and the tumor microenvironment. So our concept of biomarkers somewhat began to morph and change. And of course, our goal now of therapy is to move up to this red curve, right? Chemotherapy was good. It was better than doing nothing. Targeted therapy improved on that. Immunotherapy improved a little bit more, especially in some combinations, and some patients getting a prolonged benefit. But what we really want to understand is how do we drive the majority of our patients being treated to long-term benefits of therapy? And recently, we've had a new class of drug that's emerging, call it generically antibody-drug conjugates, bispecific T-cell engagers. I call it, it's really bringing together the best of all of our worlds. It says, how do we target our therapies to just the tumor itself, just the area that we want to deliver the therapy? And then the payload could be chemotherapy, it could be immunotherapy, it could be radiotherapy. It's how do we deliver our therapy targeted to the patient? And this creates a whole new wave of potential biomarkers that might be more helpful in identifying patients that will get maximal response to those therapies. So my main point up to this point is it's the therapies that drive our need for biomarkers, and our therapies have gotten more complex, and we need to understand more elements of the tumor, the individual, and how things are arranged to optimally select how to use these therapies in combination. I wouldn't know how to do it without an emergence of a new field that allows us to understand the inner workings of the tumor and its environment. And I would argue that while immunohistochemistry and PCR were sort of the grandfathers of biomarker testing, the thing that really drove targeted therapy over the top was the emergence of next generation sequencing, where we could recognize multiple targets in one assay, really facilitating traditional targeted therapy. And I believe that spatial biology is going to revolutionize our next wave of combinations, which are going to focus on antibody-drug conjugates and immunotherapies. So with that in mind, I just want to do a little bit of a background of what is spatial analysis. Haven't we somewhat been doing spatial analysis? And the answer is sort of, but not really. So, I can correlate spatial analysis a little bit with mapping programs that we're all familiar with. We all use Google Maps or Apple Maps to now traverse instead of a paper map. It's in essence a type of mapping software for us, but the benefits of that software quickly move from just getting from point A to point B to telling us the best route, the cheapest route, where hotels were, where gas stations were, that we could plan an event now with this software technology. Spatial analysis was also used medically to, for example, within London to identify an outbreak of cholera, where they understood where the outbreaks of cholera occurred, but they wanted to identify the source. And by mapping the locations of where the outbreaks occurred, they could centralize to the specific location of where the cause of the cholera outbreak was. And the idea from spatial analytics is to move from data into knowledge. Now, we've always mapped a tumor. So if you look at the top right, we've always visually looked at the gross configuration of a tumor to understand its extent, its relationship to margins, what it looked like, necrosis, heterogeneity. So in our mind, we were always mapping some things. And now we have some software that we can overlay on top of that that make things more interesting. But if you're going to map, the real question is, well, what exactly are you going to map? So are you going to map just, for example, I can tell a tumor cell and a lymphocyte? Or am I going to be able to tell all of the different cell types? Can I now see macrophages? Can I see mast cells? Can I see dendritic cells? And more importantly, not just can I see those cells, can I tell something about the state of the cell? Can I say that this cell is resting, this cell is exhausted, this cell is actively killing? So to do that, the question that to really understand biomarkers, the question is, can I really understand the environment that I'm looking at? And so what I'm really going to be talking about in my mind, the more that I think about this, is really the evolution of medicine, where when I started my career, and for those that came well before me, medicine was really an art and not a science, because we didn't really understand, we saw things, but we really didn't understand how they were put together. The hallmarks of cancer really changed that for us. It really broke down to what exactly is going wrong, where are the pathways that are disrupted, and how can we best target those pathways. And we really, over the last 30 years or so, 40 years, have driven to become a clinical science driven on data that we're deriving from these biomarkers. But I would argue that our biomarkers are getting so explosive and so complex that we're moving toward an era where we're going to be a data science predominantly that's going to be driven by clinicians. And pathology is going to help move that. We very slowly have been moving from art to science. Early on in my residency, my first project, I did my residency at Rush University with the chairman at the time, Ron Weinstein, who had the vision of telepathology. And I had the pleasure of building that first telepathology system while I was a resident, and could understand that now that we could take images that used to be locked in a microscope and unlock them, first visualize them anywhere around the world, but more importantly, unlock those images, allow us to digitize those images, and now deeply understand things that weren't visible to the human eye before. And that became really important because the human eye has a lot of limitations to it. There's only so much we can do as a pathologist. So I always like to show this. This is an optical illusion from MIT. So you guys shouldn't be fooled. You know you're going to be looking at an optical illusion. And we've got two squares that are marked on this, A and B. And hopefully surprising to you, it should be surprising, that A and B are actually the same color. That should be really terrifying to some of us. We're quantifying biomarkers all the time, saying this one's darker and this one's 1+ and 2+ and 3+. But you can see when we take a solid line and apply it over that, over that matrix, that the solid line blends into A and blends into B equally. And recognized early on, this is a paper that I published with really the first automated system for aiding pathologists in assessing HER2, that looked at 10 different pathologists and their ability to correlate IHC scores and FISH scores with HER2. And you can see that among the 10 pathologists in purple was their manual ability of looking at an IHC stain and then correlating that with the concordance of there being HER2 amplification by FISH. And you can see that there was very little correlation between the pathologists. To be fair, the pathologists had different levels of training. Some had very little training in HER2 assessment. Some were experts, but you can see even at, I won't even tell you who the experts are because some of the experts had the lowest correlation. It's a whole entirely different story. But you can see there was almost no uniformity. And when you give people a tool, though, an aid to help them read the slide and assess the intensity of the stain, that virtually everybody equalized, and more importantly, everybody got up to an expert level or beyond an expert level. So really, really important to improve the quality of biomarkers. And so we've always understood that giving pathologists aids is going to help us in that. So now I'm going to move and talk a little bit about deep learning and the process of spatial biology. But before I do that, we're going to have another quick pop-up question. So which type of data modality, or predominantly one, are you using? You can pick more than one answer here. So just H&E, IHC, multiplex immunofluorescence, or transcriptomics, or all of the above. See the answers? So good. So we must have a lot of researchers on here. A lot of people still using MIF and transcriptomics, which is fantastic. So what if we can unlock the thousands of spatial features hidden within the patterns of a pathology slide? So of course, the first step to do this is going to be that we're going to have to be able to digitize slides. And we would like to be able to understand as many different types of cells and cell states as we possibly can. And a pathologist's eyeball has been somewhat limiting to do that on an H&E slide. But we've used immunohistochemistry to help us identify cell types within histology slides all the time. And now with multiplex imaging and transcriptomics, it really gives us the opportunity to delve in and truly understand a myriad of different cell types and cell states. Sorry, I need to advance here. There we go. So the first step in the process of assessing the slide, no matter what type of slide it is to find the artifacts on the slide so that we aren't analyzing things that are junk. So those are typically things that are out of focus area, tissue folds, etc. Again, we don't want to be analyzing artifacts. The next thing we do is break the slide down into compartments that are areas that might be of interest to us. I'm going to explain this in greater detail, but those would be things like, what are the areas of tumor? What are the areas of stroma? What are the benign areas? What are margins, etc. And then we want to focus in what are the different types of objects that are on the slide, cells that are on the slide. And then we want to be able to classify those cells. And that's in large part going to be determined by what goes in. So if we have an H&E, we might be more limited to the cell types and states that we can identify. Whereas if we have a high-plex MIF, we'll be able to identify many more different types of cells and states of cells. And then once we have the individual cells, then we want to look at the interrelationships of all of those cells, distances, and I'm going to describe all of these different things in much greater detail in a few seconds. So in essence, starting from the bottom right and moving up, we've got a slide. We break it into areas. We classify the different cells, and then we can begin to understand the relationships of those cells. And so we're running, in essence, what is a pipeline where we pre-process the image and, again, identify the things to get to individual spatial features. The models can classify not just areas and cells and stains, but you can also train models to identify secondary structures, for example, like lymphoid aggregates and mature tertiary lymphoid structures. And if you want to understand relationships, then you need to take the slide and identify specific regions that might be of interest to you. So that could be the tumor, for example, the tumor invasive margin, the stroma that's next to the tumor, the stroma that's away from the tumor, benign areas, margins, etc. And then when we get down to spatial features, those spatial features can also be categorized in a variety of ways. We might want relationships that are focused on areas. We might want relationships that are focused on cell distributions, the number of lymphocytes, for example, that are in an area. We might care about the interactions of cells, how close a lymphocyte is to a tumor cell or a macrophage is to a dendritic cell, or the distribution of specific features. So there's a large variety of different things that we can do. And to do that, we need to, again, as a first step to me as a pathologist, you need to give me a way to interact with the slide. So I need to have some sort of areas that I care about. And those things need to be configurable because they're going to change depending on what my question is, right? If I'm looking at something like inflammatory bowel disease, I don't even have a tumor. I don't have that concept, but I do have the concept of a diseased area and a normal area, for example. And so this just highlights, ways in which that can be done. So in red color, if you look at the middle, the reddish area are areas of tumor. The greenish areas are areas of stroma, or in this case, we'll call it the tumor microenvironment. And then in the image of the left, we could break those down even further. So we can look at the red area, for example, and then there's sort of a dark red in the core and then a bright red at the edge. The bright red would be the invasive margin of that segment of tumor. So it's directly abutting the adjacent TME, whereas the core is away. It's sort of surrounded by the tumor itself. And we can look at that tumor microenvironment the same way. We can look at the tumor microenvironment that's directly abutting the tumor, or the tumor microenvironment that's further away. And of course, you can define those with any distances that you want. But these categories become very, very important because it's the way that we're going to understand the spatial relationships that we uncover. So I'm going to use an example here of CD8 topology to understand the sorts of things that you might be able to do. So all of us, I mean, I know many projects for different pharma and clinically where the question is, tell me about the CD8 cells that are in the slide for a variety of things. Stromal TILs would probably be the best example of that in triple negative breast cancers, where the level of stromal TILs has been associated with outcome. And so, we can train pathologists to go as a 10% or 20% or 30%. But TILs can be looked at in a wide variety of different ways. So for example, we can look, like in the case of stromal TILs, at the fraction or density, but we can also look at the proximity of TILs to tumor. We can look at the heterogeneity. I mean, it's great to say that we have stromal TILs that are 40% overall, but are they 90% in one area, 0 in another, and 40 elsewhere? And then there's other things that might affect the TILs, like fibroblast barriers and other things that might affect how those things function. So those are all things that spatial analysis can provide for us that have always been in the slide, but that we've largely been unable to do by eyeball. And we know, for example, that TIL scoring has been used to stratify patients. We've also done studies in checkpoint inhibitor therapy in combination with other immunotherapies, showing that the percent TILs, especially in the parenchyma, not necessarily in the stroma, are correlated with much better outcome. And one of the issues, when you uncover that is you go, great, let's just train pathologists to do that. But it becomes really hard for pathologists to reproducibly see those parenchymal TILs and to score them easily. It's much easier to score the stromal TILs where the background's a little bit easier to see. So if you ask pathologists to score these parenchymal TILs, you get high variability and low accuracy, very little reproducibility. But these are things that spatial analysis can do quickly, cheaply, and easily. Now let's just talk about some of the features that you could extract. So maybe I'll blow your mind a little bit with all of the different things that you could just do with like CD8 cells to get different measurements. And of course, a lot of these measurements are going to be correlated. But if you're looking for a specific biomarker that could be used to predict outcome in the future, one of these measurements might be key. And as you look at the details of the measurement, you could see how difficult it would be for a pathologist's eyeball to recapitulate all of these things. So let's start out with just trying to understand the presence of CD8 within different compartments. So we could do the number of CD8 cells, for example, within a certain tumor area. We could do the number of CD8 cells within an area and divide that by all the cells that are within a tumor area. Or we could do, for example, the CD8 cells versus only relative to only the number of tumor cells in an area. So those are the differences between densities, fractions, or ratios. 3 different numbers, but highly interrelated. We could also, since we've arbitrarily broken up our tumor into these different area compartments, we can look at the relative amounts of CD8 cells within each compartment. So we can say how many of the CD8s are within the tumor, are within the tumor core, are at the tumor margin, are in the tumor microenvironment at the margin, or remote within the tumor microenvironment. So all of those things, again, we're now subcompartmentalizing and do things hard enough for pathologists' eyeball just to quantify CD8s. Now we want it by regions. It makes it much more challenging. And then we get into things that are the cell-to-cell interactions. We call these neighborhood analyses. And this becomes really tricky. So I'm just going to walk through the different combinations of things that you can see, just so that you get a feel of it. And so we've got this massively oversimplified example of 3 neighborhoods that we're going to look at. One of the neighborhoods is that 30 micron yellow circle, the 30 micron blue circle, and the 30 micron green circle. And within those, we've identified what we'll call the target cell that we put in X, that's in the middle of that 30 micron segment. And then within that segment, we're just going to concentrate on tumor cells and CD8 cells. And we're going to classify the CD8 cells as CD8 cells that are CD8 T cells, basically, or lymphocytes that are basically CD8 positive versus lymphocytes that are CD8 negative. So you can see, for example, we can take a look at the first horizontal line. We say the mean percent of neighbor cells within 30 microns from a target cell. So that's basically saying how many lymphocytes, how many positive CD8 lymphocytes are there in the neighborhood of that target cell. And so if you look at that 30 micron circle in the right, you can see that there's 2 filled in yellow circles, meaning the CD8 positive cell within that segment. Within the yellow circle, there would be 7 lymphocytes, and within the green circle, there would be none. So if we asked a yes/no question of it, which is sort of the middle row, is there at least one CD8 positive cell adjacent to a tumor cell? You could see for the blue circle, the answer would be yes. For the yellow circle, the answer would be yes. And for the red circle, the answer would be no. And what if we just wanted the ratio of the tumor cell to any lymphocyte, whether it was CD8 positive or CD8 negative, or we wanted to know relative to the tumor cell, what was the ratio of CD8 positive lymphocytes to CD8 negative lymphocytes. And then you can see the ratio in the in the blue circle would be 2 out of 2. In the yellow circle, 7 positive and 2 negative. And in the green, of course, there's none. So these are things that we can calculate for every cell, get an overall analysis, virtually impossible to do by eyeball. And then we could talk about things like, what is the percentage of CD8 cells that are present across that entire radius? Meaning, is there a high average number of lymphocytes by each tumor cell, or is there a low number? And we can grade that on a scale. And again, impossible to do by eyeball, but easy to do with spatial analysis. And for example, we know that some of the responses to checkpoint inhibitor therapy were related to the relative distance of the CD8 positive lymphocytes relative to the invasive margin of the tumor. So these are things that can be easily calculated. Obviously, an eyeball can do it when something's massively infiltrated or not infiltrated at all. But these degrees in between can be quantified very easily with spatial analysis. And that allows us to get much better at predicting things, for example, like immunophenotype. For those of you that have tried to classify cells as inflamed, excluded in deserts, you recognize the obvious ones quite easily. But for the majority of slides that you look at, that definition becomes very, very difficult to reproduce and isn't very consistent between pathologists. So using hard facts, hard science, and calculations, we can now redefine those categories or create new categories based on real data, based on the number of CD8 positive cells within various fractions that you can better define. One of the other really big problems that I've always had as a pathologist and that we struggle with all of the time is heterogeneity. So we love in pathology to give a single score. We have to call a tumor one way or another. They'll ask us for, again, TILs. What's the percent of stromal TILs in the microenvironment? And, it could be 30%, but the distribution of that 30% could be wildly different. Or I like to say, especially with antibody-drug conjugate therapies, we might pick a cutoff of saying we need tumor cells to be expressing the target in 10%. The question exactly is, well, where is the 10%? Are they all bunched together in one corner of the tumor? Or are they uniformly spread throughout the tumor? Because you can imagine that the drug would hone in differently. Its effect would be different. And so you can break a tumor up through a process called tessellation, which is simply breaking them up into tiles of specific sizes. And you can make those sizes as large or small as you want. And then calculating all of those individual spatial features that I just described, the literally hundreds to thousands of different things that you could calculate. And then you could build a map of what that looks like per square. And that gives you a great sense of the heterogeneity that's present within the tumor that otherwise might have been overlooked. And you could do that same thing by applying other cell types too. Even if you're interested in CD8 cells, you might want to understand their relationships between fibroblasts or other entities, non-tumor entities, and how those might be affecting your overall relationships. So we can see that just for something as simple as TILs, it sounded really, really simple, that we can really break that down into a continuous quantification that now has degrees of heterogeneity, and that we can really conceive of new biomarkers out of that simple marker that might address better treatments for specific patient types. So I'm going to switch gears one more time, but we're going to ask one more pop-up question here first. And so can we see the pop-up? So what is this one? You only get to pick one choice. So what is the biggest challenge in your work today? Pre-analytic variation, having reliable assays, digitizing slides, data analysis, interpretation of the data, regulatory or other. All right, can we see responses? So data interpretation, I would put up there. For me, that's my biggest thing too. But all of these have to work well for the data interpretation to have meaning. And there are challenges as we see across the board. So I'm just going to walk through a couple of case examples where we've used some of these methodologies to help us solve some specific problems. The first one is PD-L1 assessment, non-small cell lung cancer. It's an entry criterion virtually all non-small lung cell cancers clinical trials. There's an element of where your PD-L1 status is. Clinically, it's obviously critically important to derive therapy, whether the patient has strong expression, weak expression, or no expression. And as you would gather, when you show pathologists the same slides, there's not perfect agreement. There's good agreement. We've done a lot of effort in training pathologists how to reproducibly score PD-L1 slides, but there's a huge drift in pathologists over time. So we're pretty good when we're trained, but 6 months after training, unless we've refreshed continually, you see a significant drift. And one of the things that we've recognized with that is that, again, as I showed you with HER2 25 years ago, giving pathologists tools that assist them in the read, that point things out to them, help them overcome things that they otherwise would have looked. And so in this series that we looked at, in the middle were the pathologist calls of a number of PD-L1 cases. This was a TPS score only on non-small cell lung cancer cases. And you can see that there was a large number of cases in this cohort where the pathologist scored the cases as negative. But when they re-looked at those cases with digital assistance, 19 of those were actually categorized as PD-L1 lows. And one of the cases moved into PD-L1 high. So that's 20 patients overall that might have had different criteria for enrolling in trial. And importantly, even more importantly, clinically might have been treated differently based on that derived score. So we've known that for a long time, that giving pathologists assist tools really does make their reads better. Doesn't improve above an expert pathologist, but gets them up to that expert pathologist level. And more importantly, makes the group of pathologists very reproducible. I think a more important analysis that's just starting to emerge is different types of analysis that might become important in antibody-drug conjugate therapy. Remember, I described sort of the antibody-drug conjugate therapy as, we have an antibody that serves as a target to hone the drug to an area of tumor, and then a payload is delivered, frequently a microdose of chemotherapy, but it could be others. It could be dragging in activated T cells, it could be radiotherapy, et cetera. And so this now raises some issues, because if we're bringing a drug into targeted areas of a tumor, we sort of want to understand lots more things about that target. So now we would like to know how much of that target is there, where exactly that target is, heterogeneity, et cetera, is it in that corner or spread out? And the reason we care about that is because some of the payloads that we deliver have what we call bystander effects. You can think of it more as a hand grenade. We drop the hand grenade and we kill not just where we dropped it, but a small area around it. And so we don't care whether that small area around it, whether those cells express the target or not, because they're going to get killed by that explosion. And so now it becomes more incumbent on a pathologist to understand a continuous score. Well, that's impossible for us to do. We can look at a HER2 score, for example, and say, okay, this is 2+ or 3+, but we're not looking at that in individual cells and saying, well, this cell is 3 plus and this cell is 1 plus and this cell is 0 and this, that becomes much more difficult. And understanding those spatial relationships becomes critical if that so-called bystander effect is important for the payload. So obviously, it's pretty easy to develop models to do things like, oh, we can figure out whether this particular cell has a complete membrane stain or a partial membrane stain or no membrane stain. We can apply intensity models to it fairly easily to go, is it strong, medium, or weak? And we can apply cell models to go, are you a tumor cell? Are you a lymphocyte? Are you whatever? But we want these things to be more continuous than what an eyeball is able to do. And this is recent work that was published by the group out of AstraZeneca, taking a look at in HER2 in a series of low HER2 expressing tumors. I believe these were gastric tumors. And they asked the question, was there be an outcome difference? So the patients had some response, which was great, but would there be an outcome difference if they measured not just HER2 positive or negative, not just is HER2 more than 10% of the cells expressing HER2 at some level of expression, but brought in the concept of a proximity score. So now they wanted to know in the HER2 negative cells, is that HER2 negative cell next to a HER2 positive cell? Or is that HER2 negative cell far away from a HER2 positive cell? And it turns out when you break that out into two categories, you get the graph that you see in the upper right-hand corner, which is you start seeing survival differences. That those HER2 negative cells that were far away, if you take that over the whole slide and create what they call a spatial proximity score, that those with a lower score do significantly worse than those with the higher spatial proximity score. So now this becomes something that's impossible for a pathologist's eyeball to do. We can't start looking at negative cells individually and then try to guess how they fit relative in relationship to positive cells. That's just too difficult for an eyeball. But again, relatively simple for spatial analysis. And another case example is one of my favorite things to do, having been the earliest adopter of digital pathology. We immediately had two use cases that became really significant for us. One was, if you did chromogenic multiplexing, which, by the way, we were doing in the 1970s. This is not new stuff. Could we now digitize that slide and break it into component parts? So could I now, for example, I have a lymphoma and I'm going to work up my lymphoma and I'm going to do 12 immunostains. That requires 12 sections. Can I reduce that to 4 triplexes, for example? And now I don't have to waste 12 sections. Now I can do it on 4 sections. And more importantly, when I become digital, I don't have to digitize 12 slides anymore. I can digitize 4 slides. And when I take up spots in my stainer, hopefully they can go continuous. I don't have to take up 12 spots. I can take up 4 spots. So for workflow issues, independent of all the cool analysis that you can do afterwards, this is going to become a really exciting technique, I believe, within pathology. And one of the things that we're doing already is we're being asked to quantify multiplex stains, and especially where the compartments are overlapped. And you want to say, does this cell co-express both markers or neither marker? And so again, very difficult to do by eyeball, but very simple to do with analysis. And one of the things that we frequently get is that you already have independent singleplex IHC markers, but the question that you have is a spatial question, and you want to know relationships between slides. So we can apply these AI techniques to do what we call virtual multiplexing, take the 2 slides and basically synthesize them into a single slide. And I'm not going to go into all of the details, but it's far more complicated than just registering a slide and overlaying them. It's really using AI to do alignment, create probability maps, and then be able to project one stain on top of the other stain. And you can see that on the example on the bottom right, where we've overlaid a density map of a CD marker on top of PD-L1 expression. And of course, I'd be remiss if I didn't talk about the other things that we can do with AI, the so-called black box AIs, where we can deep learn signatures with enough examples. And those can be signatures of individual cell types. They could be true signatures like interferon gamma signatures or suppressive cell signatures. We can even attempt to mirror a variety of immunostains like CD8 or 163. And the idea behind this is to try to simplify the more complex techniques that we have out there to better identify patients who need to have more complex testing, or to screen out patients who could just move on to therapies. There's a wide variety of different things that this technique could be used for. We just call it deep learning H&E to whatever you want. You need to have an outcome, and then we deep learn to that particular outcome. So there's lots of things that are around in moving AI that can aid clinical trials as well. Obviously, aiding pathologists to really improve that manual assessment, even including it as a secondary endpoint. So it might be able to be listed in some labels of drugs that you could look at it either manually or with the aid of imaging techniques. It can help decentralize some clinical trials. A big problem is if you're enrolling all your patients based on PD-L1 status and you go, well, it's an FDA cleared assay, we'll just enroll locally. I think I've showed you already that you could be missing a significant number of patients without that image enhanced tools. And especially when you're looking for rare events that need to be found by expensive, complex assays, training an AI algorithm to better predict that off of an H&E, so that you need to test that, one, you don't let any patient fall through a gap, but more importantly, that you can more effectively screen for patients who might actually be enrolled in your particular trial. So really what I'm talking about at the end, just to summarize up, is moving where I grew up from in the phenotypic world to combining that with genomics to really create biological data and try to move medicine into this clinical science. But I think where we're really moving is now adding computation and machine learning to really move us into this data science world of health intelligence. And it's going to be incumbent on physicians to understand how to navigate this new world, to use these tools effectively to get patients the best care. I think the use of AI-driven biomarkers in treatment decisions is inevitable. It's not a question of if, it's only a question of when. And I think for a significant number of these things, the answer is right now. So with that, I'll end, and I think we've got some time for some questions and answers.
Yes, Dr. Bloom, thank you again for a very insightful talk. We're now going to take a few questions. We don't have so much time, so we'll try to get in as many as we can. Just a reminder, if you have any questions, you can submit them via the chat window below. And if we don't get to them, then you can email them to info@nucleai.ai. So we'll start with our first question. Dr. Bloom, can you touch a bit more on how you see spatial biology or digital pathology being adopted in a clinical and pharma setting?
Yeah, so it's interesting to think of the barriers to digital pathology. And I think the barriers are basically among ourselves. So I'm going to tell you just a little bit of a story. So I was one of the co-founders of Clariant Labs, and its original medical director and chief medical officer. And one of the things that I did at the outset of Clariant, which was a reference lab, local pathologists would send in slides to be scanned or molecular tested at our laboratory because the technique wasn't available within their lab. And one of the first things that we decided was every slide was going to be digitized, and we were going to provide a portal back to any client where they could view our slides online, so they could learn to drive the slides. And the adoption of that technology, this was 2005 when we started, the adoption was 100%. That's all you had to do was show it to somebody, and they were in. Now, there was another feature to that, which I believe is truly important. I paid for the technology. So I bought the scanners. I was paying for the digitization and everything else. They got to use it in essence for free or as an add-on before they got their slides physically returned to them. And so when it's free, the barrier to adoption is zero. So I'm 100% convinced, because even 20 years ago, it was zero. And by the way, we were scanning 1 million slides a year. So it's not, I don't want to hear about, we couldn't storage and you can't stay, scanners weren't fast enough and everything else. That was just not true. Now, what are the barriers today? The barriers are, they're several fold, right? There are some barriers of, how do I bring in the equipment? How do I move this equipment? The scanners themselves, how do I bring them in? How do I move them into a workflow? How do I manage these images that I'm now creating, especially if I want to manage these long term? What do I do with these images? And so there's a variety of companies now that are servicing that purpose, that are image management systems, they're scanning systems. We've got things that are FDA cleared. So that's a money barrier and a workflow barrier. But the biggest barrier has been, yeah, so what benefit do I get out of it? Right? What do I get? And I think what we haven't done is the things that pathologists need every day, which are the tools that aid them in their job. And we haven't really done that. We've built the special use cases only on the tough cases. I'll give you the aid for PD-L1. I'll give you the aid for HER2. And people adopt that relatively well, but we haven't got it into, just let me overview every slide that I look at and tell me something about this slide that I didn't already know that was going to be clinically important. And the key is, it's all there. It's there, right? It's astounding to me that people haven't done this in either academic centers or in a commercial lab, because there's so much value hidden in the slide that's available today. So the barriers, I think, are economic and workflow more than anything. They used to be regulatory, right? And the regulatory hurdles, I think, are done. And I think now so that's the immediate barrier. But the bigger barrier is you have to make useful tools, things that pathologists can actually use in an easy to use way, not in, I need to get off of what I'm doing and move to a different environment and do 9 million other things and then I get an answer. It has to be, the answer comes while you're looking. We're just not quite there yet.
Right. Thank you. I see we have time, I think, for 1 or 2 more questions. The next question we have is about quantifying the fibroblast barrier when looking at TIL analysis. So Dr. Bloom, could you tell us a bit more about what features can provide specific insights, or a bit more about the significance of quantifying this?
Sure. So I can't go into great detail because the studies have not been fully published yet. But I can tell you that our group and others have clearly identified that the ratio of fibroblasts, for example, to we'll call it inflammatory elements within the tumor microenvironment, that the more fibroblasts you have, the less effective those therapies become. And so there are a whole variety of different relationships that you can quantify relative to that. But in its simplest terms, if you were looking for, like, what's the relationship? Clearly, the more fibroblasts, the less effective those immunotherapies are. And there can be a variety of reasons for that, that not going to go into now, but there's a whole variety of reasons that you could more deeply explore with these spatial analysis tools.
Gotcha. And I think we'll do one last question. This last question is about CD8 quantification. And if we are able to do some CD8 scoring or get an idea of that without the IHC staining, exclusively from the H&E slide.
So this is a fantastic question. And the bottom line is, I don't think we 100% know the answer yet. You can definitely train models to look to know the outcome of the CD8 result and train from the H&E to be able to predict that. And you'll predict that with an accuracy level. So the AUCs, when we do these black box models, generally range anywhere from like a 0.75 to the low 0.9s. So some you can do pretty effectively. Some are a little bit weaker. I'm a huge believer that we need to do better than what we're currently doing on H&E slides, because everybody has trained their H&E models to a pathologist's eyeball. And I think a pathologist's eyeball is just somewhat limited. Now, the other comment that I'm going to make about predicting things like CD8 from an H&E is, how good is your CD8 antibody? Because one of the things that I frequently see is we get stains for CD8 all the time. And while they stain the CD8 positive lymphocytes, they stain other things as well. And so it's not as specific as what you think. They do capture all of the CD8 positive cells. So you really need to understand the sensitivity and specificity of your particular assay if you're going to deep learn the H&E to it. And I think that's been another problem, is that people are trying to learn off of substandard assays. And so you're never going to be better than what you train to, unfortunately. So the answer is yes, it's possible. So if you only had the H&E slide and you didn't have another slide available to do a CD8, and you didn't want to destain your H&E to do a CD8 stain on top of it, we could apply a predictive algorithm. It will not be 100%. You're not doing the same as replacing it, but you're getting a good estimate, probably in the, AUCs of 0.85 range of, yes, that is a lymphocyte and likely a CD8 positive.
Great. I think have run out of time. Dr. Bloom, thank you again for a wonderful talk. If you could proceed to the next slide. Yes. So if anyone has any more questions or wants to learn anything more, you can reach us at our website, nucleai.ai, or Dr. Bloom directly at his email attached here.
Thanks, everybody.